Good morning, everyone. So, today we are going to discuss point of care ultrasound in palliative medicine, how it can be useful. Actually, this topic is first time we are discussing in this forum. Uh, the idea came when Shunmuga Priya took this lecture for our department, and I realized that she took it extremely well, as I realized that it is very important for everyone, those who are practicing palliative medicine. So that's why in series 6 we are starting with this lecture, that how a point of ultrasound can be useful. I know that it is not going to be easy to procure ultrasound for all the facilities wherever you are working, but at least you can keep in your mind that how it is important and how beautifully it can help you in management of your patient. So Shunmuga Priya, please. Shunmuga Priya is our junior resident of palliative medicine. She's third year junior resident of palliative medicine, in between second and third year basically. And Shunmuga Priya, please go ahead.
Good morning, ma'am. Good morning, everyone. Today, my topic is on point of care ultrasound in palliative medicine. Thank you, Sushma ma'am, for guiding me throughout the preparation. So now let's see the objectives of our topic. Today is introduction to the topic and then ultrasound basics, application of this point of care ultrasound in palliative medicine, integration of point of care ultrasound in palliative care, and conclusion. With the time restriction, I'll be maximum trying to cover the basic aspects of ultrasound and its use in palliative medicine patients. So introduction. What is this point of care ultrasound? The POCUS is point of care ultrasound, which is a bedside ultrasound done by the treating physician in evaluation of some clinical findings or as a guidance for some interventional procedures. So this is a rapidly emerging and widely practiced, and it is practiced by the non-radiology physicians like emergency medicine, anesthesiologist, cardiologist, gynecologist, ICU in their routine basic evaluation of their patients. Since it is a real-time imaging and it is very affordable, it is widely used. So now let's see that because of the importance which has been realized over its use, now it is time to integrate the insemination part as the fifth pillar of our routine bedside physical examination. So this will improve the physical examination, and help you reach the diagnosis more confidently as a physician. So let's get familiarized with the ultrasound probe parts. So in the picture I have displayed here, you see the power cable, and this will be the metal outer casting. And in front you have the plastic noose, and behind that you have two blue lines, which is denoting the electrodes, and an alternating potential difference happens between these two. And it is filled with the piezoelectric crystals. So on stimulation, this piezoelectric crystal oscillates to produce a very high frequency sound wave signal. So ultrasounds are basically the use of this high frequency signals, which is more than 20,000 hertz beyond the audible human range, and this sound waves is used to generate the image. So in ultrasonography, you can see this this probe, the piezoelectric transducer, is capable of both emitting and also receiving this ultrasound back. So the named effects are reverse piezoelectric effect, where the electrical signals are converted into the mechanical waves, and direct piezoelectric effect, where the mechanical pressure which is produced by this target object is reflected back as the ultrasound to the electrical signals. So now let's see the orientation of the probe. You can this is the patient, and you can keep your probe either transversely or sagittally or in a coronal section as per your interest of study. So now how to interpret this sonographic image? So everything is based on the brightness. This is called echogenicity, which is nothing but the brightness. So the echogenic, what is the echogenic potential? So this is the ability of any structure to produce the echoes. Based on the volume or the intensity of this returning echoes, the image is going to be brighter or in a darker shade. So this is like when it is completely black, it is called anechoic. When it is little lighter than the surrounding structure, it will be interpreted as hypoechoic. When it is in same echogenicity, is called isoechogenic, and in hyperechoic, you see this bright white structure. That means it is brighter than the surrounding, which is called hyperechoic. So now let's see the tissue impedance. As I told, every tissue will have its own reflecting or the echogenic producing capacity. So fluid is always the friend of ultrasound. So it is going to allow all the waves that it gets to travel across it. Whereas the tissues can be like, it could be a soft tissue or a fibrous tissue, and it depends on the volume of the nature of the tissue. And then comes bone is like not going to allow any of the waves to across, and air is always an enemy, or it always produces artifacts in ultrasound that it's going to refract all the waves which is going to come in across. So as you see, these are the tissues which we are studying, and how we will see the ultrasound picture. As I told, fluid is a friend of ultrasound. It will be complete black picture. And when it is a soft tissue or a fibrous tissue, depending on the intensity, it could be either gray or it could be in a brighter shade. And when it is a stones or bones, you will see first a hyperechoic rim, and beyond that, it will be completely dark, which we will call as an acoustic shadowing. And whereas in air, it will be an alternate black and white gray, black, white, and a grayscale because of the artifacts that is created. So the knobology, the probes which are going to help you in in our regular practice are linear probe, curvilinear probe, and the phased array probe. So these probes, the frequency ranges of the linear probe is going to be 5 to 10 megahertz, and in curvilinear probe it is 2 to 5 megahertz, and in a phased array probe it is going to be 1 to 5 megahertz. So the image depth also varies with each probe. Basically, this linear probe will have a higher frequency range, but the depth of imaging will be less, like 9 centimeter, and the resolution will be good. So this will be used to visualize superficial structures like artery, veins, and when you need some assistance in procedures, and eyes, breast, testicles, some musculoskeletal system, etc. Whereas the curvilinear probe, it has a wider range of coverage, like it can cover to a depth of 30 centimeter and has a lesser frequency, like 2 to 5 megahertz, and the resolution will also be poor. But it is used widely to visualize all the abdominal pelvic organs. And the phased array, it is 1 to 5 megahertz, and the depth of range is 35 centimeter, and it is visualized used to visualize heart, inferior vena cava, lungs, etc. So before we step into the steps of our steps of our ultrasound screening, it is important to learn about the care of your ultrasound machine. You have to clean your probe every time before you use it for the next patient, and you have to disinfect it adequately, and you have to store it in a safe place. So in case if you forget, and after every use to clean even the jelly, then it can cause accumulation and the probe can be damaged in long term. So now let's get familiarized with the transducer movements. So you can either slide your transducer, or you can fan your transducer, or rock your transducer. It is just to get more view of your area of interest. So sliding is when you move the probe completely, like either in any of the direction of your interest. Whereas rotating and tilting is like when you do it against the perpendicular. It is like perpendicular to the probe pointer. And rocking is like along the probe pointer. So the modes of ultrasound. When we use ultrasound, we have 4 modes which is commonly used. One is the amplitude mode, or the A mode, which is used for accurate depth measurements in departments like ophthalmology, echoencephalography, echocardiology. And next is the brightness mode, which is widely used among us. That is two-dimensional images are produced in this, which helps in producing a image of the slice of a tissue, which is based on the intensity of the echoes received back to the transducer. And then comes the M mode, or the motion mode. It is a one-dimensional image, and the movement of the structure is produced over the time. So this is used in echo, fetal cardiac imaging, etc. And then comes the Doppler mode. Here, the energy which is scattered from the moving RBC, it gets shifted to a higher frequency when it moves towards the probe, and it gets to a lower frequency when it is moving away from the probe. And this has 3 different types. One is pulse rate Doppler, where you can put your cursor to a specific location and study. And then comes the continuous wave Doppler in situations like regurgitant or stenotic lesions, and the color Doppler, which we'll use widely in DVT screening. So the application of POCUS in our regular practice, one is diagnostic POCUS, another is interventional POCUS. Today our class is more based on the diagnostic POCUS, that is thoracic POCUS, abdominal POCUS, optic nerve sheath diameter, DVT screening, and a little 2 or 3 slides on echo and also IVC visualization. Whereas the interventional POCUS, it is used widely in our palliative medicine for thoracocentesis, paracentesis, difficult intravenous cannulations, and nerve block. So now let's come to the system-wise ultrasound examination. First is the thoracic ultrasound. Here will be the all our all the above all the ahead slides will be based on this international evidence-based recommendations for point of lung ultrasound, because this was a literature study which was done between 1966 to 2011. Available literature were all gone through by 28 panel of 28 experts from 8 different countries, and they have given a recommendations where we can guide where it is a standard implementation guide. So other things will be like indications in palliative medicine and the blue protocol. So in lung ultrasound, we our color code is blue protocol. So then the positioning of the patient. So you can prefer the you can prefer your patient to be in a supine position when you are screening for the lung field. So the few pathology where you can, which is like the preferred segment for screening a pathology like pneumothorax and B-lines will be the anterior segment, and the middle or the lateral segment will be used to screen for pleural effusion, and the posterior segment in case of pneumonia. So the thoracic focus indications in palliative care will be like our common clinical findings which we come across as pulmonary edema, pleural effusions, pneumothorax, hydropneumothorax, pneumonia, and pulmonary embolism. It will be better with a guided echo. So the lung ultrasound in critical ill. This is the blue protocol. This is like a very fast protocol which can be performed less than 3 minutes when you have to make a diagnosis of acute respiratory failure. Since we don't have any dedicated protocols for palliative medicine, we are just following the standard protocols available for now. So to familiarize with the blue protocol, they have discussed 10 signs. We should be familiarized with the 10 signs. So first I'll be discussing the signs of blue protocol, and then we'll see the blue points, and then we will be going to the proper blue protocol. So first, what is the normal lung ultrasound? How do you visualize? So once you place your probe in the patient chest wall, the first thing you have to start locating is the pleural line. Whenever you start your lung ultrasound. So what is this pleural line? This white, bright white structure you see in the starting of the lung field is called the pleural line. So this is the hyperechoic line of the visceral and the parietal pleura intervention point. Then comes the bad sign. Bad sign is when the consecutive rib shadows, that is this the rib above and the rib below, along with this lung field, will be visualized as a bad sign. So then comes the lung sliding. The visceral pleura and the parietal pleura moving relative to one another with each respiratory cycle, as you can see in this image. And then comes the A-lines. A-lines are this A-line, as I have told, any sign you're going to read in a lung ultrasound is because of artifacts, as lung does not have, lung when it is filled with air, and air is going to produce only artifacts. So A lines are these horizontal lines you see on the screen, and this signifies it is an aerated lung, and this will be parallel to the pleural lines, and it will be multiple in number. Usually the distance will be equal between this pleural line and the skin. So now let us read about this B lines or the B profile. As I have told, A lines will be horizontal lines. This B lines are going to be comparatively vertical lines. There are 7 points you have to remember about the B lines. One is it is going to be an artifact, and these are all vertical lines, and it will extend from the pleural line, and it will extend till the edge of your screen. And it will move with respiration. It is hyperechoic, that is white in color, and it will be also called as comet tail sign. So how are these B lines formed? So the formation of comet B line is that once your transducer emits the ultrasound wave, it is going to hit this, when this ultrasound wave meets any thickened interstitial area, it is going to get reflected and it forms an artifact. This is the first reflection, and from similar process keeps continuing to the nth time. So all these reflections are getting recorded as consecutive lines behind with 1 millimeter gap. And this eventually you happen to visualize it as in vertical lines, that is the B lines. So what is the significance of this B line, or what is B profile? So when do you call it as it to be positive? Because B lines, seeing one B line, it does not mean it is positive. So positive zone means that is there should be more than or equal to 3 B lines in a longitudinal plane between the two ribs, and it should be more than 2 positive zone per side. And when this is there, we call it as interstitial syndrome. So interstitial syndrome can be any of these three pathologies below. One is pulmonary edema. It could be cardiogenic and non-cardiogenic, or it could be pneumonia, or it could be pulmonary fibrosis. So then comes the curtain sign. So curtain sign is the overlap of the costophrenic recess onto the abdomen, and it creates a demarcating edge. So this is like you see the lung to move above, to come above the liver, and it looks like a curtain. So this is also an important sign of normality, which means the lung is aerated, and it is the diaphragm is moving along with the lung. So it also signifies that you have reached the inferior aspect of your lung, and beyond which it is going to be the abdominal region. So now let's see the pleural effusion. So how do you visualize pleural effusion? As I have discussed previously, fluid is the friend of ultrasound. So it will be seen as dark color, and it is how do we interpret it? As anechoic. So when you place your probe, you'll be seeing the lung, you'll be seeing the fluid collection, and you'll be visualizing the diaphragm and then the liver. So this will be your picture for pleural effusion. And when you see this lung floating in this large effusion, it is also called as jellyfish sign. And next comes the quad sign and sinusoid sign. Quad sign is when you have placed your probe and you have seen the effusion here, and you see the rib shadow. This is the rib above and the rib below, and this is the lung border. So using these borders, we form 4 rectangular borders, which is called the quad sign. And then comes a sinusoid sign. In this quad sign, when you place your M mode pointer here, the lung, because as it moves and comes in and out of the field, it creates a sinus wave pattern, which is called the sinusoid sign. And then comes the spine sign, which is very definitive, and it is present only when there is fluid collection. So since this fluid collection is going to allow all the waves which is going to pass through it, the waves are capable to reach till the thoracic spine, and the thoracic spine is visualized. So this is very definitive for fluid in the thoracic cavity. This is called as spine sign. And this plankton sign is when you see small echoes within an anechoic background, that is the fluid background. This simply signifies that it is an exudative collection. And then comes the mirror sign. Mirror sign is when the lung, this is also a normal sign when the lung is present aerated, when the lung is aerated. So the air is going to create artifacts as I have discussed earlier. So this is the diaphragm, and you see a defect in this liver echogenicity, and you see the similar image getting created in the lung field also. This is called as, this is the liver field, this is the lung field, and this is the diaphragm, and you see the similar image on both the sides. This is called as mirror sign. This will be absent when there is pleural effusion. When there is some collection here, this will not be present because air will not be there to create an artifact. So this is will be absent in the presence of pleural effusion. So how is this mirror image artifact created? When there is an interface between two different densities. They reflect the sound waves very vigorously and end up in producing a mirror artifact in the opposite side. So here the strong reflector is the diaphragm, and this is the existing object in the liver. So when it gets reflected vigorously, it creates a mirror artifact in the lung field also. So now let's come to pneumothorax, where we have to visualize the lung point. Lung point, as we have discussed earlier, when we keep the probe, we always look for the pleural line in the thoracic ultrasound. So here we have seen the pleural line, and you see the one half of the lung is having the sliding sign, whereas the other half is remaining little static. So this is called the lung point, where the visceral pleura begins to separate from the parietal pleura in a case of pneumothorax. This is called the margin of pneumothorax or the entry point. This is called as a lung point. So now to confirm further, pneumothorax does, when the lung point, when there is absent sliding scale, it does not mean it is only pneumothorax. There are other conditions also, which I will discuss in further slides. So first point, first sign is the lung point, and next is that we place our cursor on M mode. So when you see this seashore sign is that the lung tissue which is moving out and in during respiration will be considered as the beach, which is having and this chest wall will be considered as the waves. So this will be present when there is normal lung function. So when there is a static lung, when there is pneumothorax, this lung is not going to move, and this will have like barcode, it will mimic a barcode or a stratosphere sign. It will be just seen as a parallel horizontal lines. So then comes the lung pulse. This is this lung pulse sign is also included in blue protocol. So we'll cover what is it. So this is also a dynamic lung ultrasound, and it is more usual during it is more helpful during to confirm any complete atelectasis due to selective intubation. It is more helpful in anesthetist and ICU team. And it has a sensitivity of 93% and specificity of 100% for diagnosis. So that is when you see the lung field and you put a M mode, and you will see the heartbeat getting transmitted with each cycle. So this you see as T waves. This you see as a different wave in this corresponding to the ventricular function. So this will not be seen in the pneumothorax. When there is T line, it means it is atelectatic lung, not an pneumothorax lung. So as I told, pneumothorax, just absent lung sliding does not mean it is pneumothorax. We have to, it has to fulfill 3 criteria. That is, one is absent lung sign, and it should have a lung point, and there should be barcode sign or M mode. So absent lung sign, the other pathologies are, one is single lung intubation, and pleural adhesions, pulmonary infiltrates, severe pneumonia, and atelectasis. So the content is that normal lung sliding means 100% there is no pneumothorax, but absent lung sliding does not signify it is only pneumothorax. It has other differential diagnosis also. So you have to go for visualizing the lung point and the barcode sign to be more confirm in your diagnosis. So then pneumonia. Pneumonia is like when you see the you see there is loss of A lines. As we discussed earlier, A lines are present in a normally aerated lung. So in this, there will be loss of A lines, and the lungs will have a liver-like echogenicity, and there will be dynamic air bronchograms. So the first sign which you have to visualize is the Stretch sign. Stretch sign is normally seen in the consolidated lung. So you see an irregular border and a hypoechogenic area in the subpleural region. So this is also called as fractal sign. Shredded meaning it is irregular. So this means the normally the aeration of the normal lung is abated. So then comes the air bronchogram. Air bronchogram is that normally the bronchus should be dark in color, but because of some pathology in the alveoli or the airspace, it is going to be visualized as white. As you can see in these 2 images, you see this white echogenicity. So this can be either static or dynamic. Dynamic is that with every cycle of respiration, you see the air coming in and going out. So this is dynamic, where it could be static also. And then comes pulmonary embolism. So how far this thoracic ultrasound can help us in pulmonary embolism? So this is evaluated. This is a comparison study between the effect of thoracic ultrasound and CT angiography in diagnosis of pulmonary embolism, and had a good sensitivity, specificity, and it can be used as a bedside tool when you have a clinical suspicion. So how do you visualize it? One is that there are 3 things you have to remember. One, you'll see it is a pleural-based lesion, and it will have a complete wedge-shaped or a rounded definitive border, and it will have a hypoechoic area inside. It can be added with or without pleural effusion, but always echo should be followed. Echo should be done following it, so to be more diagnostic. So these are the 10 signs we have familiarized till now. One is the pleural line and the sliding scale, sliding line, and sliding sign, and A line, B line, quad sign, sinusoid sign, lung point, fractal sign, lung pulse, and the air bronchograms. These are the 10 signs they have mentioned in the blue protocol. So we have seen what all should we see in the blue protocol. So now then we will see where should we see. So these are the 3 blue points which we should know where should we place our probe. So the lower we in a supine patient, you place your palms. You place both your palms from the below the clavicular line and the midpoint of the palm. And this is the imaginary point. So the line drawn from the mid clavicular line, corresponding to the angle of Lewis, will be the first the upper blue point, and the lower blue point is when the anterior axillary line is corresponding to this midpoint of this palm, and the posterior or the PLAPS point, the posterolateral alveolar and the pleural syndrome, it is actually the horizontal extension of this lower blue point, and the vertical line will be from the posterior axillary line. So the intersection of these 2 points is considered as the PLAPS point. This is the protocol proper. So let us revise everything as a whole. In a lung, you have got a patient in acute respiratory failure. So now let's see the lung protocol. We place the thoracic probe, we place the ultrasound probe, and you see the lung sliding present. So when it is present, and then you go visualize the B profile. This should be done in all the 2 points, like the upper point and the lower point. B profile, it means there is pulmonary edema. So when the lung sliding is present and it is still the A profile and the patient is having acute respiratory distress, you should go for sequential venous analysis for ruling out any thrombosed vein to not miss any diagnosis of pulmonary embolism. And if there are still free veins, then you should visualize the PLAP point, that is the posterior point, where if you find any significant finding, it could be pneumonia. If there is no PLAP finding, then it could be any exacerbation of COPD or asthma. When the lung sliding is absent, then you go visualizing for the next sign, which is the B profile. If it is present, then it is pneumonia. If there is still A profile, then you go look for the lung point. Lung point, then if any lung point is present, it is pneumothorax. Without lung point, then you have to need other diagnostic evaluation to ruling out. And this pneumonia can have any combination of this above. So it could be lung sliding present, absent, it could have A or pre-profile. So pneumonia can have wide presentation. So just a revision, in pleural effusion, we have jellyfish sign, quad sign, sinusoid sign, spine sign, plankton sign, absent mirror sign. And in pneumothorax, we have lung point, absent lung sliding, barcode or the stratosphere sign, absent seashore sign. And in pneumonia, we have Schett sign, fractal sign, and air bronchograms, which could be static or dynamic. And in pulmonary embolism, we have pleural-based, wedge-shaped hypoechoic lesions with or without pleural effusion. So we have finished the thoracic ultrasound. Now let's learn about the DVT screening, which is more important in our patients. The basic concept of this DVT is like you have to have a linear probe in your hand, and you should be able to visualize the vessels, and always prefer your probe pointer to be on the right side of the patient. So there are 3 things which we have to look in these patients. One is non-compressibility of the veins, and there will be visible clot, and there may or may not be. And then we should also go for a color Doppler screening. As you see in the first image, the vessels are visualized and you are doing the compressibility test and the veins are compressible. And here you see the color Doppler image. And in this, since there is clot, you see the color filling defect. The inner part does not have any color flow, whereas only the peripheral rim, because there is a presence of thrombus. So let's have a look in the anatomy of our lower limb veins, which is more important for screening. So one is the in the external iliac artery. Our point of interest will be in the common femoral. This is the saphenofemoral vein, and this will be the superficial femoral vein. So once it drains into it, it forms the common femoral vein and continues as external iliac vein. So our point of interest of study will be mainly here, and also the popliteal veins. So this is split into zone 1 and zone 2. Zone 1 and zone 2, there are 3 points, but the most preferred zone 1 and zone 2. One is where you visualize the saphenofemoral vein draining into the this you can see in the right side picture, the ultrasonographic image. You can see the great saphenous vein, which is draining into the common femoral vein. And here you see the popliteal vein and the popliteal artery. In between, it will be the continuation of this it will be the continuation of the superficial femoral vein. So let's see the steps of, as I told, it could be 2-point leg ultrasound, 3-point leg ultrasound, or a whole leg ultrasound. So this is a full screening image. First, you when you want to screen for the saphenofemoral junction, you start your probe from below the inguinal ligament and you keep tracing it. So you see, these are two lumens. One is more defined and one is like a not very well defined. It could be, it is like, this could be vein. So there now when you slide your probe down, you see the greater saphenous vein draining into it, and you just keep doing the 3 steps. One is compressibility, and then put the color Doppler and see, and you have to just keep tracing it till the vein vanish, till the vein fades away from the screen. So you see this greater saphenous vein draining into the superficial femoral vein, and this will be continued throughout the thigh till it disappears. And this is how you visualize your popliteal vein. And this is how you visualize your popliteal vein. You place your patient in a lateral position, either right or left lateral, based on your study of area of interest, and you place your probe in a slightly flexed knee, and you visualize the artery and the vein, and you try to compress it. So this is the screening for popliteal vein DVT screen. So here you see both the veins and the arteries, and you do the routine 3-step. One is compressibility, and then you go for the Doppler study. Here, as I have already told, you just trace the vein till it moves away from your visual field. So once you come down, popliteal vein will have its own tributaries, and you have to trace it till that. So what is false positive and false negative DVT? False positive is there are chances you will see an artery which is very thick, and it will be seen as a non-compressible vein. So then comes lymphadenopathy, which is also sometimes misinterpreted as a clot inside the vein, and there is a smoke in the vein effect, which is also misinterpreted as clot, and there is the vector of force is incorrect. And false negative is when you fail to check the compressibility. You just when we just see just the color Doppler or the thing, and we move on, and some weak anatomical orientation. So the negative DVT screen does not rule out DVT. And when there is a high clinical suspicion of DVT and there is a negative DVT screening, it is always advised to go for a repeat DVT screening. So here I am sharing one of our patients' ultrasound of it. Here you see this is the vein, and it had a hyperechogenicity, the smoke in vein effect, which I have discussed earlier. So here we were sure that it was not a clot. So we have put the we have checked the compressibility, and then we switched over to the color Doppler mode. Here you can still see the hyperechogenicity. So since even if you are not confirmed, you can go for the pulse wave Doppler, which we have discussed, and you can see the flow in the vein. So if you want more confirmation, you can
just a minute. Shunmuga Priya,
yes,
the important points you can take time. I have told you to go fast but these are very important. So you just explain it well. Okay, don't worry.
Yes,
don't worry about
it. Yes.
Yeah, good.
Yes, ma'am. Okay. This you see, there are 2 vessels you are visualizing, and in one vessel you see some white echogenic structure. We have a tendency to interpret it as a clot. So in this case, to make it more sure, we have put a color Doppler, and we have done the compressibility testing, as you have seen. So to be more confident, we have put the pulse waved Doppler, and we see the waves which is generated from the veins and the artery. I'll show you the difference. So here is the vein flow. So when you compress the probe and you do the compressibility testing, there will be no waves. And when you switch over to the artery, you will be able to see the artery waves. You will be able to see the biphasic waves in an artery. That is the difference between the veins and the arteries. So this turbulency in veins, it is not a clot, but there is a recent paper which is published during the COVID times, as 2 patients who had this turbulency in veins landed up in venous thromboembolism, even though they had no acute proximal DVT present during that time. So they have hypothesized that this could be an early indicator of a venous stasis in COVID patients, and could be associated with risk of developing future venous thromboembolism. So this could be, this can be of more interest of study in future. So this turbulence of veins is not to be missed also. So now comes abdominal POCUS in palliative care. So what are the findings which we are going to get will be malignant ascites, malignant bowel obstruction, hydroureteronephrosis, and urinary retention. So the area of interest will be the right upper quadrant, left upper quadrant, subxiphoid region, and the suprapubic, and the whole of the abdomen in case of a malignant bowel obstruction. So in abdominal ultrasound, we'll be focusing on the black pattern. So here the basic concept of an abdominal ultrasound is that you are going to assess the fluid. So when the fluid is present, as it is a friend of ultrasound, it is going to look anechoic or black in the picture. So you are just going to see how whether there is, I'll show you the tabular column, which is more easier to understand. So you are going to look for the areas where it is black, where normal blackness is not expected, like in a pleural effusion, like in a ascites, or in a rupture of the bladder, or in any arterial rupture, ruptured aneurysm. So this can cause free fluid collection in the abdomen, which will be black. So this is area where blackness is not expected, but there is black, and there is too much black. These are some areas where there is normal fluid collection, like urinary bladder or a gallbladder, where there is where due to some pathologies there could be over distended bladder, or a thickened GB thickening, or an obstructed GB flow, which is causing distension of the gallbladder. So this is like too much black. These are just a hint to come to the pathogenesis. And then comes black that is not clearly black, that is different shades of black. Like when there is some lesion, it will have different different echogenicity. So it will not be black, it will be kind of grayish with a different echogenicity. So example, it could be a thrombus, or it could be cystitis, or it could be some stones. So now we come to the abdominal ultrasound. So this is the most easiest diagnosis even a beginner can make in an ultrasound. So in the abdominal field, when you see this free fluid collection, this is the ascitic collection, and it could be either, it also, ultrasound also helps you decide like whether to intervene in that or not, because sometimes in some malignancies like ovarian malignancies, there is more chances of septations in the ascitic collection, which even with the tapping, the patient cannot be benefited. So you can see the differences between both. And the malignant bowel obstruction. Malignant bowel obstruction is the most common presentation we have. It is the most common presentation we have. Many patients ending up in emergency medicine, and we have to wait for many radiological investigations to confirm it. Whereas ultrasound can be a good bedside tool to have a good clinical suspicion. This is have 2-3 papers which is showing the difference on the efficacy of the bedside ultrasound. This was a 6 hours training program between the emergency medicine and the radiology residents in the diagnosis of small bowel obstruction. And the diagnostic accuracy between them were not statistically different, but still there could be 2-3 findings which they have told, which can be used as a criteria for diagnosing it. One is the presence of a dilated bowel loop that is more than 2.5 centimeter of jejunum and 1.5 centimeter of ileum. It was the most sensitive finding in these patients. So this is the diagnostic accuracy which was done by the emergency medicine residents, and they have come up with 2 more things. One is as we have discussed, one is 2.5 centimeter of the ileum and 1.5 centimeter at jejunum, or the wall thickness of the lumen can be more than 3 millimeter, and the interloop free fluid, that is the ascites present between them, is also seen in few cases. And regularly in our routine practice, we are using abdominal X-ray as an first radiological diagnosis, as the first radiological investigation we often order in a case of obstipation. So comparing, this study was done to compare the ultrasound sensitivity with the abdominal X-ray. See here you see the abdominal X-ray sensitivity was 46% and 66% specificity, whereas the ultrasound finding, the 2 finding which we have discussed before, one is the dilated bowel loop and the decreased peristalsis, together as a comparison had a very good sensitivity of 93% and 81% specificity in diagnosing malignant bowel obstruction. So this is how you'll be visualizing the malignant bowel obstruction. You will have a thick bowel loop, that is the thickness will be more than 3 millimeter, and the lumen diameter can be more than 2.5 centimeter. And this is the Tanga sign, that is between the 2 loops you see free fluid, that is the ascites in the abdomen. This is called as the Tanga sign, and you should be very careful not to miss any spot in the whole abdomen. You should screen the whole abdomen. So this is the to and fro peristalsis in an obstructed bowel. You can see the fecal content and the intraluminal content going ahead and going above and below. And this is called the altered peristalsis. And here you are able to visualize the Tanga sign also. So now let's visualize the kidney. So in our patients, we have many patients who have deranged renal function test, and the cause of the renal function test with an presence of ultrasound, you can make out whether it is an acute or a chronic kidney. So for that, we should have a little familiarization with the kidney ultrasound also. So first is the probe position. In a longitudinal view, you hold the probe such that the pointer in the probe is towards the head of the patient. So this is the longitudinal view you will have in the image. So you see the hyperechogenic white area in the center, which is the renal medulla, and the outer cortex, which is like the cortex of the thing, which is comparatively iso or hyperechogenic. So the location will be in the right side in the mid-axillary line. It is in the 10th and the 11th intercostal space for the right kidney, whereas on the left side along the posterior axillary line in the 8th and 10th intercostal space. This is the longitudinal view. So when you want to have a transverse view, you always tilt your probe such that the probe pointer, which was towards the head of the patient, is rotated in the anti-clockwise direction. And now you have the transverse view. The area of visualization will be similar. You will be visualizing whether the renal cortex and the renal medulla. So the common findings which we get is the hydronephrosis, like you see the dilated kidney, where because of the stasis of the urine, you see that it is cystic collection in the kidney. And then comes the chronic kidney disease, where you see the kidney as a shrunken structure, and there is no corticomedullary differentiation as we appreciated in the before pictures. So next is the renal calculi, where you can see, as we have discussed before, in bones and stones, you will see this hyperechogenic, that is the white structure, and the posterior acoustic shadowing, which is the dark background beyond it. So even to be more confirm, you can put a Doppler and see in small stones also. It is very helpful as it will mimic a twinkle sign. So this is a case scenario. Due to times, I'm just skipping the scenario, and we'll come to the
No. Go ahead with the scenario session. No, Priya, don't worry.
Okay.
This is the only way that everybody will learn.
Okay.
We have 15 minutes. We have 15 minutes.
We had an 8-year-old female kid who presented to our OPD with a severe abdominal pain, who was referred from the medical oncology OPD. She was a case of Ewing sarcoma of the left thigh primarily, with a diffuse metastatic status currently, and she had a progressive disease in spite of her oncological treatments. So she presented to the medical oncology OPD, who were their primary treating physicians, with an acute onset abdominal swelling and a severe pain, like NRS was 8 to 10 on presentation, and she was crying in the OPD. So the patient, and she was the family and the parents also gave a history that patient is immobilized, like the kid was literally bedridden for 2-3 days due to pain, and no clinical benefit with ongoing chemo. So they have advised further evaluation, as we know the patient load in our OPD. So they have advised further evaluation with ultrasound abdomen, pelvic imaging, and also documented best supportive care here, after the thing. And the patient was referred to palliative medicine OPD for pain management and supportive care. So on examination, we also had a palpable mass which was firm to hard, and there was mild tenderness in the periabdominal finding. So we have admitted the patient, we have admitted the kid, and we evaluated, and we did a routine bedside ultrasound as a regular examination. And we found this cystic swelling in the suprapubic area. Guess what? It was just a distended bladder because of the locally advanced disease. There was obstruction in the bladder outlet, so there was a distended bladder, and this was the cause for. And the patient had, since she was wearing only diapers and she was passing bedside, the parents also were not able to notice like whether she has passed urine or not. So there was distended bladder. With Foley's catheterization and pain optimization, we were able to counsel the patient for home-based care and discharge the patient. So how do you do this bladder imaging? And the most important imaging, along with the thoracic, abdomen, and the DVT screening, one more imaging is the bladder imaging, which we should never miss in our patients, because the history will be very vague that they have passed urine, and the attendants cannot cannot be very confident in that. So in this, you place your probe in the suprapubic region, that is, the pointer should be towards the head of the patient, and this will be the longitudinal view. So what are the organs you will be visualizing? One is the bladder. As you can see, as fluid is present inside, so it is going to be anechoic or black in color. And then comes the uterus or prostate in males, and you can see some bubble gas surrounding it, and the rectum as at the lowest. So in this, you can see the cystic pouch in the suprapubic region. So now you can, similarly, to have a transverse view, you just rotate your probe in the anti-clockwise direction such that the pointer comes to the right shoulder of the patient. So here also you will be able to visualize bladder, uterus or prostate in males, and the rectum. And one more main important thing is that some patients who present to us will come with the Foley's inside and will be and the patient's urine bag will be empty for 2 days, 3 days. So we'll be thinking that the patient is having nil urine output, but sometimes it could be just a blocked Foley's catheter which is present inside you. So to even with the patient with Foley's, it is always good to check the bladder status with admission. So when the patient is having a functioning Foley's, this is how you will visualize the Foley's bulb. It is because that you use the fluid to inflate the bulb, no? So that is seen as a clear bulb. So you can see the rim, and inside there will be a fluid collection. So this is the Foley's bulb. So in this picture on the left, you see an empty bladder. That is only Foley's bulb is visualized. It means the Foley's is functioning. Whereas in the right, in spite of the Foley's present inside, it is having a distended and a cystic swelling surrounding it, which means the Foley's is either blocked and it is not functioning, and it requires intervention to change the Foley's. So now we come to the optic nerve sheath diameter. This will be more useful when you suspect patients having a raised intracranial pressure, like with metastasis, intracranial mets. So this is also a good tool when, as we all know, even though magnetic resonance imaging is the definitive study to measure the optic nerve sheath diameter, but this could be a more effective bedside tool. So in this study, they have compared between the ultrasound and the magnetic resonance imaging. So you see, they have given the location where you have to visualize, that is 3 millimeter behind the papilla, and it was having a good reproducibility, and the inter-observer variation was also less. So in this study, they have this was a systemic review and a meta-analysis paper where they have given, and the sensitivity and the specificity of this was very good. And they have concluded that ultrasonographic optic nerve sheath diameter may be a potentially useful approach for assessing intracranial hypertension when all the imaging is not available or indicated. So this is the steps we follow in our routine practice here to visualize the optic nerve sheath diameter. You keep the patient in supine position, and you will be choosing the linear probe because you are going to visualize eyeball, which is a superficial structure. You can either use your regular ultrasound jelly, or better also you can go for a normal saline, which we use in our routine practice here. So we choose a linear probe in a supine position, and we visualize the globe by placing the probe and the jelly. And we have to visualize where it is 3 millimeter behind the globe. Why this location is important? Because optic nerve sheath is in continuity with the dura mater of the brain and the subarachnoid space. So whenever there is going to be any series of pressure variations, this will also have influence in this optic nerve sheath diameter with fluctuations in the anterior retrobulbar compartment, which is approximately 3 millimeter behind the globe. So here you see in the right side, you can see in this image, you see the globe like this and the optic nerve sheath, which is in a black shade. So this will be the papilla. This is the area where it starts. So you freeze the screen and you will be placing your distance. You'll be able to measure the caliper here. So you place the first point here and you measure 3 millimeter from here, or 0.3 centimeter, and that will be displayed on the screen. So here you make the second caliper, that is the transverse measurement from here to here, the visualized part. So this will be counted as your optic nerve sheath diameter. Here they have displayed it is 0.62 centimeter. That is the second distance. So what is the normal range? In infants, it is less than 4 millimeter. And in more than 1 year, it is 4.5 millimeter. And in adults, it is considered to be less than 5 millimeter. So any patient, any adult you're having more than, in an average Indian adult, it could be 5 to 5.5 millimeter, and above that, it is considered to be a dilated optic nerve. So 3 more slides on echo also. I'm not going in depth, but this is something basic. We should all know how to do an echo. So the phase probe array is phase array probe is chosen here, and this is a simple mnemonic, that is the golden circle or the golden spiral for doing echo. So these arrows here are just signifying the pointer of the probe where it should be placed. So in the starting of the circle, you place your probe in the second, third intercostal space on the left side of the chest wall, and the pointer is towards the right side of the shoulder of the patient. So this will give you the parasternal long axis view. And when you rotate the probe in the clockwise direction, the pointer is going to come towards the left side of the shoulder. This will be the parasternal short axis view. So next you come such a way, then you again rotate it clockwise. So now the place should be in the apex of the apex. So it is somewhere around the nipple. So this will show you the apical four-chamber view. And then the subxiphoid region will have the subxiphoid view. And further you rotate your probe such that the pointer is towards the umbilicus. Now you can visualize the IVC also. So here in the parasternal long axis view, you'll be able to visualize the right ventricle at the top and the left ventricle, left atrium along with aorta. And in the parasternal short axis, you will be visualizing only the ventricles. In the apical four-chamber view, the right ventricle and the right atrium will be at the top, and the left ventricle and the left you'll visualize. So in the subxiphoid also, you'll be able to visualize all the four along with IVC also entering into the right atrium. And in the IVC visualization, it is important for all of us because most of our patients, the IV fluid rehydration is also important. So you can use this as a marker to hydrate your patient when the caliper of this IVC is between 1.5 to 2.5 centimeter with some collapse with respiration, it is a normal thing. If it is less than 1.5 centimeter and there is a complete collapse, the patient could be in hypovolemia. And if it is more than 2.5 and there is no change with respiration, it could be hypervolemia or overhydration of the patient. So these are the ultrasonographic images. This is the parasternal long axis view where you see the right ventricle at the top. And this is the short axis view where you see only the ventricles. And this is the apical four-chamber view where the pointer will have the left ventricle will be close to the pointer and you'll see all the four chambers. And in the subcostal or the subxiphoid, the four-chamber view, you will see the IVC also entering into the right atrium. So the we should be able to pick up at least the most clinical emergency conditions like pericardial effusion in our patients who present with some refractory breathlessness. So when you place your probe, you'll be able to visualize the heart very easily and always look for the collection surrounding the heart, restricting its normal function. So in this patient, you can see they are having a gross pleural effusion where the heart's contractility is very much compromised. So this is for the IVC. IVC can be visualized in three different things. One is in the longitudinal view or in the transverse or in the coronal from the right side of the patient, right side lateral aspect of the patient. So the normal anatomy, as we all know, this is the aorta and the IVC will be little to the right of the aorta. So when you visualize in the longitudinal view, the pointer towards the head of the patient, you are seeing the IVC here, which is entering into the right atrium. You can put the color Doppler and be more precise. So in this, we are rotating the probe in the transverse view, and here we see the vertebral body, and the aorta is going to be above the vertebral body, and you seeing the IVC a little to the right of it. So when this visualization in this, you can see this is the aorta and this is the IVC. So sometimes because of our malignancy like pancreatic mass or something, you'll not be able to visualize this clearly. So you can go for the, like as we do for the renal imaging, we can choose that location and we can visualize from there. You see the liver here and IVC will be immediately beneath it and the aorta will be beneath it. So when you can see the size and the diameter of the IVC here also. So only one intervention I'm covering today, that is intravenous access. We all have faced so many difficulties in securing an IV access in our patients because of post-chemo status and generally the anorexic condition of the patient also. So the recommendation is that if you have 2 or more failed attempts, you can go for an IV, the ultrasound guided IV access, or you can, if you're having a difficulty, you have an anticipated that there will be difficulty peripheral access, it is always better to choose. So you here also you will be using a linear probe. You have tied the tourniquet, you keep your probe, and you will be visualizing the needle in the screen, and this will be the vessel, this will be the vein. So you can take a more confident prick here. These are a few of our available articles on the diagnostic and the interventional studies with ultrasound only for the palliative patients. So since 2009 till now, there are very limited research available, and from our institution we have 2 important papers. One in 2011, we have a bedside ultrasound, which is a radiological boom for the placement of complex nerve blocks for abdominal malignancies. This was one example for interventional guidance with ultrasound. And this is the paper which was published by Sushma ma'am and our team. So in this, they have discussed the need for the this they have discussed the potential of the ultrasound as a very good tool for complex nerve blocks in abdominal malignancies. And in 2015, there is another paper which is exclusively for diagnostic workup in palliative care, that is utility and potential of bedside ultrasound and palliative care, which is again published by our radiology team along with Dr. Sushma ma'am in Indian Journal of Palliative Care. All these articles have their link in this. You can click and you can read all the articles. So this is that article where ma'am and our team, they have discussed all the common indications like malignant pleural effusion, ascites, nerve blocks, intravenous access, evaluation of urinary obstruction, deep vein thrombosis and abscess in this paper. So further, and my current thesis is also going on in the same topic. So my primary objective is to find any positive findings in an early integration, like a bedside ultrasound will be done on every patient on admission, like all other major departments like pulmonary medicine, emergency medicine, where it is all practiced in their routine. So we should also take initiative in in doing more research in this. These are few images from my own thesis work. So in this first image, you can see the liver metastatic lesions. Where this is called as target or bullseye lesion, where you see a hypoechogenic or the black area surrounding the bright white area. This signifies liver metastasis. And this is the jellyfish sign, where you see the lung floating in the pleural fluid in one of our admitted patients. So this is more interesting, where you see the bowel obstruction in admitted patients at ward. So here you see the intraluminal contents having altered peristaltic moon, to and fro movement, and the lumen is also more than 3 millimeter, and the intraluminal diameter is also around 3 centimeter. And here you'll be able to visualize the Tango sign also, where there is flea fluid between both the bowel lobes. And this is example for the Foley's visualization in a patient with a functioning Foley's. The patient is having severe ascites, the gross ascites, and the patient also had a Foley's incisive which was functioning, as the bladder surrounding it was empty. So how can we take it further in our routine practice of palliative medicine? Our patients they have both inpatient visit, outpatient visit, and home care visit also. This ultrasound is with more technology and miniaturization. Ultrasound has come now with this wireless Bluetooth access in our smartphones also. So this is going to be of very good use to us if we start practicing it from now on and get familiarized in that. So this will be helping our patients in their home-based visits also. So this is a publication from a geriatric team. They have come up with their own protocol for home-based visit, that is home-oriented ultrasound exam, that is HOUSE. So in this, they are in every of their visit, they are screening the JVP and then the lung and cardiac limiter, like which we have covered today, and IVC status, DBT screening, and a bladder volume, which is all, this will cover more or less the 80% of the presenting complaints in our patients also. So how can we make this possible? The 5 pillars of establishing POCUS. One is the governance, that is based on the teaching should be also be there, and infrastructure, that is the equipment you need. Administration, the workflow should be good, and the patient load. And education, the training required, hands-on training required for ultrasound, and the quality. Once you start doing it, and by that your skills will also increase. So they have proposed 5 essential pillars of POCUS that is necessary for any hospital-based training. So now let's come to the final point. So hospice and palliative medicine ultrasound. We have many patients who are in like very terminal, or since the trajectory has changed, we are seeing many patients from the starting of the disease also, like since the diagnosis. So we also should improve our diagnostic skills further to pick up any progression in disease, and any new symptoms or signs should be addressed adequately. So this point of ultrasound in hospice and palliative medicine is like a really evolving thing. And palliative care does not mean there is no care. So we should always not hesitate to do some non-invasive at a simple bedside examination like an ultrasound in our patient, because we have some presumptive diagnosis. There could be something new. So even if it is not new, at least we'll have some more confidence in making the diagnosis. So we should all prefer doing an ultrasound to all our patients who get admitted with us. So the conclusion is that this POCUS can help the clinicians improve their diagnostic skills with accuracy, confidence, and critical decision making at the bedside without any delay. And it is not a replacement, or it is not this is more important, this is not a replacement to the ultrasound done by the radiologist. Whenever you have some doubts, whenever you have you need any help, always don't hesitate to ask anybody else. So time saving, and it is most affordable, and it is easy to use. So the introduction of this POCUS curricula and training at the medical school and postgraduate level is very important, because there is increasing level of evidence of its effect in the clinical practice. And the advances in all these handheld systems of point will possibly, it is more or less like POCUS will become a standard tool of the frontline clinician hereafter. Thank you.
Thank you, Shunmuga Priya. Thank you very much. First of all, I think everybody must be like, everybody must be thinking of clapping and honor. So, Shunmuga Priya, this was such an important and fantastic class. And I know that time is, we are already overshooted 4 minutes, and we don't like overshooting time. But I just want to say that this class definitely will motivate you that you should have an ultrasound in your practice. Wherever you are practicing, you should have an ultrasound. And you have seen that with the basic knowledge of ultrasound, we can do a lot for the patient. We can immediately diagnose, we can avoid MRI, we can avoid X-ray, we can avoid unnecessary sending patient anywhere, because now it's a bedside ultrasound. And now the technology has further advancement, that now through Bluetooth we can also have a patient at home, and then they can put the probe and we can see on our smartphone, something like this. So I'm not sure when this day will come in India, but definitely if we will try, everybody will try, this can happen in India also. So ultrasound has become a routine practice. Every resident knows how to do ultrasound, basic ultrasound in all our patients. It is lying in every ward, both the wards in National Cancer Institute as well as in AIIMS. So every resident, they understand that how to do basic ultrasound. And Shunmuga Priya, you have seen that she is just a second year MD palliative medicine student, and she has got so much of knowledge because she has learned from the beginning. So I just wanted to say that it was an extraordinary beginning of 6th series of lecture, and I wish that all the lectures will be thought-provoking, motivating, and will give a new direction to all of us. And thank you, Shunmuga Priya. This was most important, which we have told everybody, that this is an important tool, and it is one-time purchase. There is no maintenance cost, there is nothing consumables required. It is just one-time purchase. Try to motivate your administrator that this is an important machine and we should have in your ward. And the amount of good work you will do, automatically administration will give you a lot of good things. So this will all depend on how much you are doing hard work, how much you are sincere, and how much you want to do good practice. Thank you very much. And I'm so sorry, we have
What's
taken
the one-time cost? What's the one-time cost?
It is just between 15 to 20 lakhs. It must be less than this, because there is now very big competition. GE is coming, Sonosite is there, Philips is there. So now competition is high, and all the machines are good. All the machines are good. So it is not that one machine. When we purchased it, it was only Sonosite, so it was very expensive. But now everybody are coming. All the good companies are coming with a good machines. So I think this cost will go down.
I started ultrasound in Baptist Hospital in 81.
Yes.
92. So it was very nice. Thank you, Shunmuga Priya.
I'm so sorry, I cannot take comments from anybody, because now it's time to go to for our work. Thank you very much. See you on next Monday. Thank you, Shunmuga Priya. Very well done, Shunmuga Priya. I'm so happy and proud of my residents. Thanks a lot.